Hi, thanks. Happy to have the opportunity to present here. I'm a PGY4 from Walter Reed, and I'll be happy to talk to you today about open versus minimally invasive segmental small bowel resection for patients who have Crohn's disease, evaluating the NSQIP database. So I have nothing to disclose, and the views in this presentation do not reflect the United States government or the Department of Defense. So just a little bit of background. So I think all of us know that Crohn's disease is characterized by transmural inflammation that can affect any part of the GI tract. Approximately 80% of patients will have some sort of small bowel involvement, with 1/3 of those patients having ileal involvement exclusively in the small bowel. Despite the preference to medically optimize these patients to avoid surgery, we find that a high percentage of them, about 50% of patients by 10 years, will require some sort of resection for their disease. Use of minimally invasive surgery for Crohn's disease is still somewhat controversial for several reasons. Often these patients can present in extremis, and the appropriateness of laparoscopy is questionable in those situations. Also, due to the anatomy and nature of the disease process, with inflamed bowel, thickened mesentery with increased vascularity, these patients can be at high risk for injury and manipulating the bowel laparoscopically. And additionally, because of the inflammation, normal tissue planes are often distorted. However, despite that, there have been many studies retrospectively and prospectively looking at minimally invasive surgery for patients who have Crohn's disease, mostly in the ileocecal region, as that's the most common place where these patients present. It's showing advantages of MIS, but there's scarce literature looking at other portions of the small bowel or even colon demonstrating a benefit for minimally invasive surgery. So our clinical question, given that, as I mentioned earlier, about 1/3 of patients will have just isolated small bowel disease, do these patients also do equivalent or better with minimally invasive surgery compared to an open approach? So this was a retrospective study of NSQIP from 2012 to 2018. We used ICD-9 or 10 codes corresponding to Crohn's disease or complications related to Crohn's disease, and we compared patients who underwent open or minimally invasive segmental small bowel resection, excluding patients who had undergone ileocecectomy, given that there's a plethora of literature about those patients. And then additional exclusion criteria included patients with ascites, disseminated cancer, ASA class 5, or who were permanently ventilator dependent. And patients who underwent conversion to open were treated as part of the MIS group and as part of an intention to treat analysis. For our statistical analysis, we used Fisher's exact test and then multivariable logistic regression looking at outcomes. So just briefly going over the pre-op variables comparing MIS and open. So we included about 1,700 patients total, 445 patients in the MIS group and about 1,250 in the open group. Patients who underwent MIS were significantly younger by about 4 years. There was no difference in terms of sex or race, and patients who underwent MIS had slightly, but probably not clinically appreciative, higher independent functional status. Patients who underwent open surgery also tended to have significantly higher preoperative infection, but in terms of patients' other medical history, there were really no differences between groups. Also worth noting that a majority of these patients were on steroids for both groups, over 50% in the MIS and open group, but that was not statistically different between groups. And then just looking at other variables, a majority of patients who underwent open surgery also were malnourished, as indicated by a serum albumin preoperatively of less than 3, or were anemic or underwent emergency surgery as would be expected. But there were no other differences, including an ASA class, between our cohorts. And just to give a quick breakdown of what was included in our laparoscopic cohort, so a majority were coded by CPT codes as laparoscopic only, with about 25% or so as lap assisted, so this included hand assist, and then there were a handful of patients who underwent robotic approaches as well. So looking at our outcomes, we had approximately a 2% conversion rate, which was extremely low for minimally invasive surgery, and I'll get into a little bit later why I think that might have been. But looking at postoperative sepsis and wound events, those happen significantly less frequently in the MIS group compared to open, with really no difference in cardiac, renal, or pulmonary complications or VTE between groups. And then looking at other complications, so bleeding requiring transfusion, return to the operating room, significantly less likely to happen in the MIS group, The length of stay was significantly longer in the open surgery group by about 4 days, despite the fact that the mean operating time was longer in the MIS group by about 25 minutes or so. 30-day mortality was about the same. So this is our multivariable analysis, so looking at all the preoperative variables that I mentioned earlier and performing multivariable logistic regression to control for those factors. We found that in multivariable analysis, looking at the odds ratios, patients who underwent open surgery had a significantly higher odds of having wound complications, and this included superficial and deep space surgical site infections, bleeding complications requiring transfusion or return to operating room, with no other significant differences in any other of the outcomes measured. So several limitations to the study that are worth noting, particularly with regards to using the NSQIP database. So this is a retrospective review. It's prone to selection bias. We were only able to look at 30-day outcomes in NSQIP. We couldn't characterize the severity of disease for these Crohn's patients or the extent of medical therapy aside from steroid use, so we couldn't look at who was getting biologics or some of the newer therapies out there. We couldn't determine a patient's prior surgical history, which obviously influences the choice of approach for the operation. And then issues with coding, specifically looking at this study and comparing laparoscopy versus lap-assisted. Lap-assisted could mean a lot of different things, from a small 3-centimeter extraction port to a very large midline incision for an entire hand to assist. So obviously morbidity is going to be different depending on that and how it's coded. And then with complicated and uncomplicated Crohn's disease, ICD-9 did not code for complicated Crohn's disease, unfortunately. So when ICD-10 came out about 2016, most of the way through the study, that's when we were able to sort of better define patients with complicated Crohn's disease, defined by fistula, abscess, et cetera. So we weren't able to really get that specific into detail and make sure that we were comparing patients who had similar amounts of complicated disease, because it's very different operating for those patients who have abscess or fistula than patients who are just obstructed. And then NSQIP also does not provide surgeon-specific data, so years of fellowship training, years in practice, experience with laparoscopy, et cetera. And then lastly, just given the sort of lack of literature on this topic, doing a literature research, there's really no studies that focus specifically on small bowel disease, so really we have to compare our results to that of patients who require ileocecal resection. The conversion rate that we have is low, but actually within what's been reported for the ileocecal literature. And I think one of the reasons that our conversion rate was low might be related to coding abnormalities. So in conclusion, in carefully selected patients, minimally invasive segmental small bowel resection does show equivalent or improved outcomes compared to open surgery, in that despite longer operative times, we showed that there were fewer post-op wound infections, bleeding complications, and return to OR and multivariable analysis, as well as shorter median length of hospital stay. And so we conclude that where feasible, MIS can be offered to address small bowel Crohn's disease in carefully selected patients. And these patients should not proceed to open surgery alone just based on the nature of their disease. Thank you, and I'd be happy to take any questions.